So male infertility, what every gynecologist should know, is the backbone of the talk today, and time is 8:34. I'm gonna start now. And I'm so happy to know that more than 216 people have already joined us at the very beginning. So thank you everyone for joining us here. That puts me under a lot of pressure that you have had so much of faith on us. Now we have to put up a good show, all of us, and take you through this journey. Morning time is a very, very nice time. Sunday mornings, the time to eat something very nice, and it always reminds me of Lucknow. Okay, Dr. Geeta Khanna is around. She'll agree with me, or Dr. Das, or anybody from Lucknow. Lovely raat kachoris. Whenever I go to Lucknow, I always go and have them there. That's the right time to have them. But let's go to something different today. Let's build up our concepts. I will avoid quoting excess of references. But whatever we will be telling you, they'll be as latest as today morning. When I come for your classes, till half an hour back, I'm searching on the internet in case we have something new. I may not quote the references, but everything will be as latest as half an hour back. The aim of our talks or our clinical work is always to make such beautiful embryos, and this is what we are looking for in life. And so we have taken this talk for a particular reason. I always had a feeling in my mind that gynacs, all of us, we all are gynacs here, and we have a lot of embryologists and andrologists who have joined all across the world. I always thought that we don't take interest in andrology. This was my feeling. On the other side, we had a breed called urologists who are overtly qualified, and they are the ones who are helping us in andrology. But now the time is flying. I am finding that actually no one, even qualified people, the top of qualified people, they don't have much knowledge about andrology and male infertility and the reasons for low sperm count. I have seen people who come for low sperm count and they go to the who's who, the doctors, and you know what they're ordered? They are ordered uroflowmetry. It's amazing. That's the way we are working. We have people who are not having any erections, they've got erectile dysfunctions or multiple problems. They are obese. Without seeing them, they have been given tadalafil and many beautiful unique drugs which we use day in, day out. When they come back to us, when we see them, we find that their FSH is touching 40. Testes are totally atrophic. Levels of testosterone are actually gone down. LH is touching 40-50, and we are giving them tadalafil and sildenafils without even examining them. So this actually intrigued me, and I thought, let's see what we can do to build up the topic well for you. So we chose this topic for you today, and I'll be getting my strength from WHO Manual, 5th edition. I'll be getting my strength from AHRM guidelines, Part 1 and Part 2. And I'll also refer to European Academy guidelines. And within half an hour of lecture getting over, all these guidelines will reach your mailbox. So when the mail comes to us, and he's got such a semen sample, we are normally not worried. We are very happy that he can ejaculate, he can perform, and semen sample is here and we can examine them. Large number of sperms are normally present in the male, and even if few are bad, the other ones take over. So normally man ejaculates 40 to 50 million sperms in every act, and majority of them are pretty nice, and they are playing chess, they are playing guitar, they are very happy, they are drawing here. So it's a very good breed. But some of them may be sleeping somewhere, they are not good, so other ones will compensate. Gradually what we are noticing is that sperms are coming under stress, they are becoming bigger in size probably, they are getting defragmented, they are getting morphologically abnormal, and finally probably they go to sleep. Nowadays we have men who come to us with very low sperm counts or stenospermia, and then this is a bottle which we get. look at such a bottle, we are shaken up that there are few sperms or no sperms. Then what do? That's the way we actually do. The men doesn't know how to behave. And then we start telling the men and learning and learning about the various causes of male infertility. And we find that there's something called idiopathic male infertility, or there can be varicocele. So a lot of things are happening about which we will talk. And as a gynecologist, and as I always say, around 90% of the gynecologists who are the first contact point for a male patient are female gynecologists in a country. This is the impression which we have because we are not trained in this particular part. So this is a small initiative we are doing today so that we all work as a group together and we try to give man the due respect in the field of infertility. And now they always ask why the sudden increase in the male infertility. I mean, I've been taking such lectures from past now nearly 18 years, and every passing day I'm finding more and more people are enrolling. And as you can see, 255 people have already enrolled. This real requirement of the people to learn about male infertility. And why is it happening actually? Till now we have always focused on these beautiful eggs, golden eggs in the female. And this picture I show in all my talks, our focus is here. Our focus is on beautiful incubators which are costing lakhs of rupees, crores of rupees, but somehow we are not focusing on the male factor. We have incubators, laboratories, and for the men, we have a small plastic bottle and we have got this microscope. We wake up towards a man when we start getting these poor quality embryos. That's the time we start thinking, what is going wrong? We have done everything for the female, but things are not happening. And then we look at the male sperm factor. That's the time when we start looking at the male. And then we find that male has got multiple problems and around 30 to 40% of the males are the cause of the infertility in a couple. And they'll be seen by you in the initial consultation. So why every gynecologist should learn about male infertility, maybe male, female. I'm a gynecologist. I've done thousands of deliveries. I've done thousands and thousands of cesareans. I feel that when, as a male gynecologist, when we can examine the female, why can't all the female gynecologists examine the male? Just read a beautiful poem by Dr. Nupur Mittal, which is really remarkable. It gave me goosebumps too, and Pooja rightly brought out the word goosebumps. So male, I'll say that 70% of the cause of infertility is the male, either in the singular form or the combined form. And nowadays we have data to prove that. And a large number of them are due to the stress or the oxidative stress, and they account to around 87% of all the male infertile cases. Again, a figure which is shown in nearly every lecture which you attend on male infertility. Someone copies it and puts it there. But I want to take you to a different journey. Whatever is pink, because you look at the color coding, when we go towards the orange or red, this is good. So in the 1970s, we had everything was then pink or orange. A large number of babies were being born all over the world. 8, 7, 9, 4, 5, 3. Finally we have none. They're coming down to less number. And the same thing, now you look at the blue color, we have something like this. We barely have 1 to 2 children. You come to a stage where babies are not born, and what comes to your mind is that, okay, we don't want to have babies. We are ourselves using contraception. But the fact remains that actually something more is happening, and we are not able to make babies also. So my talk will focus on the various aspects of male infertility, and to bring your focus towards look at Middle East. Are having male infertility. In case you go to Central Europe, the number is very high. So around 50% in North America, 52% in Latin America. So problem is here to stay, and let's see how we fight this problem. I'll do a small storytelling. I have around 45 minutes with me. I'll take you through the journey of a couple. Again, my favorite pictures, in case you have attended my lectures before on male infertility, when the man and a woman met, they were very happy. So they were actually drawing rainbows. They were drawing a tree, and they were living in a small small hut. Everything was very simple around them. That's the way they lived. There was no problem. And as the time progressed, they built up a home, they had babies. But now what is happening is complex picture has been drawn by you and me and by everyone around us. Something called male superiority. Male can never go wrong. I hear it from everyone. Males can make a lot of babies. I think that is not correct. This was a scenario a few years back, and this is a complex picture has been drawn where the man dragged a woman to the clinician, and he was so scared. The men are actually so scared. Women are strong. The man is so scared, he'll always take his brother, his mother, his father, and drag a woman. This woman is bad. Good doctor. This was a scenario, I'll say somewhere around 15 years back. Things are changing now. In the past 4 to 5 years, things are changing. And for that, what happened, I think we were also at fault. We never knew how to examine a male, and we never took any initiative also. So things went wrong, things improved, a lot of court cases, legal issues, but now in the era, the women are getting empowered. Women are talking about multiple issues in the men, and now women are taking the men. And this is my OPD. In case you look at our OPD, which I'm seeing now, this is primarily our OPD nowadays. Men also come, but women also bring their husbands and tell us, treat them. So just remember that in the men, the sperm count may not be always the same. It is like an ECG curve. It goes up and down always. And don't overreact with a man's sperm count, but you should know when to react also. We'll come to this picture as the time goes on. A lot of marriages are breaking in India nowadays. The marriages are breaking due to impotence. And this is a scenario from 2014. Now we are waking up to it. And there are so many cases which we find that one day after the marriage, the woman says, I can't stay with a man. I want a divorce. And she wants her dowry back and everything back. Judiciary in the bedroom is going to come. Should the men undergo test for his sexuality before? This is a landmark observation. It's from the Madras High Court. I don't know what to say, but time is going to come where this may happen. This may happen, this may not happen, but the thought process is on. Then medical negligence is occurring. As more of IUI units are coming up, IVF units are coming up, things are going wrong. Many times, wrong babies are born. As you can see, white baby is born to a black couple. These things are happening nowadays. That's a time when, as a gynecologist, when majority of you are thinking about going towards IUI or an ART clinic, you must know where all the mistakes can occur. And that's a part of this slides I'm showing to you, that this can only occur when we put a wrong gamete in the female, or we use the wrong sample in the female, or probably the wrong egg also for creating a child. Such DNA tweaking is not allowed anywhere nowadays, as per the ICMR guidelines. And in case something goes wrong, nobody's going to spare us. And the fine may be 10 lakh rupees or 10 years of jail in case something happens repeatedly. So before we jump into IVF or ART, let's look inwards and see, are we ready for this particular profession or not? And in case we are ready, this is a very important part of our training. DNA finger typing is coming up in a big way. There are ICMR guidelines and blah, blah, blah. Sperms are now coming with Aadhaar and PAN cards, and so are the eggs. So be very careful when you handle any gamete. So why did we narrate this story? I wanted to tell you all this before I build up my talk towards the lecture today, that is to revisit the role of a modern day gynecologist. In India, we have around 40,000 gynecologists approximately. And of these 40,000 gynecologists, a large number, in fact, everyone is using clomiphene or letrozole, and we have around 1,800 IVF units in our country. And we find that the gynecologists nowadays, they are doing a lot of good work, They do fetal medicine, they do robotic surgeries, a lot of things are being done, and they are actually making us proud. Our women are making us proud, and I'm so happy to see the way things are going on all across the world. But the thing is that majority of them are females, and so we have to train them how to handle this fertility part. Our basic job is deliveries. Whatever we do, finally will be known by how well we can do deliveries. What is our normal delivery rate? What is our cesarean section rate? This is what we are normally looking at all the time. And wherever we go, the crowd is there, and there are double, three patients on one bed all across the country. Even in big hospitals, you don't get a bed for patient to stay. And in this scenario, today for next around 35-40 minutes, I'm going to take you towards a journey to discover this embryologist in you. We have a lot of embryologists who are logged into.
So please unmute yourself.
We find we're going to discover the embryologist in you, and for that I'll take you through a small journey. You have to know about the male genital tract, and this I think is given in every book. You can read it yourself, but the knowledge of male genital tract is very important for all of us to know. We have to know about semen analysis, and I'm sure I'm going to tell you certain good tips today, but that you'll have to learn. You'll have to learn the difference between azoospermia, cryptospermia, oligospermia, normospermia. So when there are sperms number are more than 15 million per ml, we say that person has got normal semen sample. When there are no sperms seen in the patient, when you don't find any sperms seen in the patient at any point of time, we say he's got azoospermia. But the journey is very different. We don't find any sperms, we have to centrifuge the semen sample. And after centrifugation, because we don't get any sperms, we say it is an azoospermic sample. But in case after we have done centrifugation and we find few sperms, it's called cryptospermia. Oligospermia is any number less than 15 million. So I've shown you, why have we shown you these numbers? Why have we shown you these figures? Because they are foxing. And when I talk to good people who are doing this work, when I ask what is oligospermia, people are not aware of. Leave aside pyospermias, pus cells, and multiple other more complicated things. We are not aware about the basic definitions. So I think we must learn how to differentiate between normal and abnormal, and then azoospermias, because the whole management will depend upon that. And why that's so important? Because you will learn when to refer the patient to a higher center. That's very important. Now, a person who has got testes of a size of a small thumbnail or a little fingernail, FSH of 40, LH of 40, we don't examine him. His testosterone is very low, and we keep pumping him sildenafil or tadalafil without examining him also. And on that, we also advise uroflowmetries for that patient. How do you feel? I think it's criminal. So for that, you have to know, first of all, we have to learn how to examine the patient, examine a semen sample, and then take the call. So azoospermias you have to know. And the common things which people ask us when they come to us is my semen sample normal? When the man comes to you, is my sample normal? Then he'll ask you, is modality okay? Is morphology okay? Doctor, I don't have any problem. I'm perfectly fine. Then why am I not having good sperm count? Doctor, some pus cells are present. So what should I do with the pus cells? Do they make any difference to my fertility? Doctor, can these abnormalities affect my chance of having a child? Somebody has told me to undergo DNA fragmentation test. Should I do it or not? Doctor, nobody in my whole family is having such a problem. Why am I having this problem? Why there are no sperms? Should I go and tell my wife about this, or can I hide it? Can you just take somebody else's sample and do my case? I don't smoke, I don't drink, but my sperm sample is so bad. They may say, doctor, I'm perfectly fine. I'm doing so well. I drive a big car, stay in a big house, but I don't get erections. What should I do? These are common things which people ask you. And so I'm building up my whole talk towards that endpoint, that how do you handle such people? So time to rethink and introspect. And for this, I come to the summary of part one. I've divided my talk into four parts. Part one is over, and part one summary meant, just summarize, that we have to know that not only for our own learning, but even for medical legal understandings, we have to understand the nuances of male infertility. That is number one. And even as a female gynecologist or as a female andrologist, we should be feeling free to examine a male. Because in case we won't examine, somebody else will examine, and that somebody is not qualified. And when I say they're not qualified, I have enough backup of information to say that they are not qualified. I think you are the best people to examine a male. Please start examining them. So, few daily practice points, some common applications, and some simple tests to perform. As I've told you, these are my energy sources. From where I draw all my energy, there's some beautiful bulletins from Indian Fertility Society. They're called Nexus, and they are available on the website. You can go and see them. And then definitely the latest ASRM guidelines, as I've told you, part one, part two, and the appendices, they'll be reaching you within 15 or 20 minutes of the talk getting over. So the conventional thinking is that man can always father a large number of babies. He can marry multiple women. This is a picture from Gujarat, where the man marries a more number of women because they can get more water for his home. This is from a neighboring country, Bhutan, where again, multiple marriages, Europe. And the most beautiful part is that they all look so happy. All the women are happy. The man is happy. There's happiness everywhere. So the man is able to make children. He can make children at any age, as you can see here. But now something is happening, and that brings me towards the lecture curtain raiser today. Curtain raiser means that raising the curtain over certain things about which we know, but we are not very sure about. Something has happened to the male, where his whole personality is breaking down like this. The man who was like this Arabian horse, who could marry multiple women, have multiple children up in the sky. And he's just up in the sky, don't know what to do. And you are the people, all of you are present here, you are the people who will take a pledge today, what Dr. Mittal has told us. Let's, with complete passion, we should start treating these people again. From tomorrow is Monday. I think the whole perspective of ours should change after this talk. And this is a man nowadays. He's thrown to the wall, a dirty wall, and he doesn't know what to do. Common question people ask, doctor, where do these people go? They never come to me in my OPD. I'm always there, but they don't come to me. So where does a man go actually? I always used to think, where does a man go? But now think they come to me now. But initially, where does a man go? A large number of them, they'll go to an astrologer. They'll wear a lot of stones, Neelam or Panna, and try to increase their sperm count. And they feel it's working. Maybe working, I don't challenge it. They go to such dawakhanas. The whole of Flipkart, Amazon, full of drugs which are available, and people order them online. And probably they are doing a good job. Shakranu nahi hai, come to us. Very, very nice. They, Shariri Kamzori and whatnot, they do for the people. And they want to save houses. Ghar tootne se bachaye. That's what they advertise. And people go to them because they are more commonly available. You'll find such vans in various parts of our towns, more in tier B cities, where they give you sone ka basam or some churn, and this will increase your sperm count. And probably, I don't know whether they work or not, but just a basic philosophy, and our men are going there. And they're going there because we are not taking any interest. So from today, from now onwards, let's start understanding semen analysis, how it happens, and then we will end with multiple summaries and take home messages from ASRM. So this I've already told you. You have to know how the sperms, they travel from testes, they travel up, and finally they're joined by the seminal vesicles, and they go through the prostate, and then they come out. We have around, on this picture, I think must be having around 200 alumni who have done the course for seminology with us. They'll agree that we spend around 6 hours in understanding this picture. 6 hours we talk about this, how it happens. It's not a simple thing to understand, but for this lecture, you must know that you must go and read about it. 8 out of 10 men have this problem. They have this problem either primary or secondary, and they need care, and that is treatable. So you must ask for it. Low sperm count, no sperm count, azoospermias is always a challenge, and I think by the time talk ends, you'll be learning about it. Reduced sperm motility or no motility, asthenospermia. Low sperm count is oligospermia. And recurrent infertility, unexplained infertility, recurrent ART failures, IUI failures are few things which we're going to cover today. Just understand that 31% of cases, we don't know why they're happening. We don't know why he's having male infertility. Everything looks okay, fine, but it's not working. Then it's another common condition called varicocele. And varicocele is one condition where we are very fond of because we don't examine them. So they go to a urologist, he'll put a probe, and I think every man, in case we look at his plexus, you'll find some veins present here, and directly he's taken for surgery. So these things we have to unlearn today, what is right, what is wrong, and we'll talk about them. In very nutshell, sperm count is normally 15 million. Any count less than 15 million is an abnormal sperm count. Total motility should be 40%. 40% of sperm should be moving, and out of this, 32% should be having progressive motility, meaning that they should be moving very quickly, moving in big circles all around, and that is called PR or progressive motility. Then one thing which we normally ignore is the morphology. I think nowadays morphology is a key thing. At Birla Fertility and IVF, we preserve the slide of the man till the time he doesn't conceive, and even later. So morphology is never done on a wet smear. It takes minimum 1 hour for the morphology to be done. It's not simple to do morphology. So you must ensure that morphology is done properly for any person who comes to you, and ensure that your pathologist does morphology properly, because in case he doesn't do it, then you are doomed. Then we always look at the pus cells. We have to see how many pus cells are present. In case we have more than 1 pus cell per million, there's a problem. And how do we see pus cell? I'm sure when we talk at end of the class, you'll find that every report which comes to us, this says multiple pus cells, 4 to 5 pus cells. At least I've never seen any report which says no pus cells. So when I ask, how did you diagnose the pus cells? They say, we don't know. They saw the smear and they said, morphology fine, pus cells 4 to 6. So gentlemen, ladies, gentlemen, just remember that pus cells have to be diagnosed by staining. We cannot diagnose the pus cells by doing a wet smear. We have to do either proper staining or we carry out fixation. So whenever a pathologist gives you a report with a pus cell present, ask him how he has done it. So morphology and pus cells, you promise me that you're going to ask your people how they're doing it. Multiple terms, table A 1.3 from WHO guideline will reach you within half an hour of this talk. You must read it. Terms like asthenospermia, azoospermia, these are few terms about which you have to know. Today, I'm going to give you a holistic view of the whole male factor infertility, but this one thing you must read from WHO manual. You may ask, why is morphology important? We only look at the count. We only look at the sperm count. Why should we put our mind into the morphology? What will morphology teach me? Remember, a sperm which has got a poor morphology, I'm calling poor morphology, will have abnormal shape and he'll have abnormal DNA. So for a sperm to be fertilizing an egg, for a sperm to get capacitated, a sperm to achieve hypermotility, a sperm to have capacity to bind a egg and go inside an egg and and undergo decondensation of the DNA, it has to have normal morphology. Morphology have to be normal, and more than 4% of sperm, meaning 4 out of 100 sperm should have normal morphology. And morphology can be only be tested by doing a fixed smear. It can't be done on a wet smear. This you have to know. So we have to spend for a morphology test minimum 1 hour. It takes to count 200 cells approximately. So never accept any report without properly done morphology, because in case morphology is not good, even if sperms are looking good but morphology is poor, you may not you may end up not getting a healthy pregnancy. So morphology, just we will look at the morphology, the various parts of the sperms. I won't go to it now in complete totality. This is a separate lecture series we have for around 10 hours on these things. But morphology, you have to know that morphology is important for you to learn, and morphology will guide you through the whole process. In the morphology, always focus on the head. Head is the most important part, and look at the number of vacuoles in the acrosomal area. This is what I want to tell you. Morphology we can do by a pre-stained slides, which I don't like anymore. They don't give you much outcome. We have to prepare our own staining methods. Second message which comes to us is, my sperms are all dead or majority are not moving. What do I do about these sperms? So the answer is, sperms are dead, go in for a donor sperm cycle. Never. There is no role of a donor cycle when the sperms are dead. There are multiple ways to find out. Because sperms are alive or not, we can't make out by looking at it. To know whether they are alive or dead, we have to do vitality staining. Some of the sperms are not moving, but they are probably tired. They are sleeping. They are not dead. This you have to understand. So whenever you get a report that sperms are not working well, they are having poor motility and they are not moving, don't assume that they are dead sperms. Probably they are having some sort of stress, they are under some sort of injury. So we have to diagnose that injury and carry out some tests for that, and finally we can treat them. So for that we got a test called vitality testing. I won't go into the details of this, but you should know, ask your pathologist to carry out the vitality testing. In fact, we do it for every patient who comes to us, and it doesn't cost any money at all. It is barely cost you rupees 4 to 5 or 10 rupees per test. It's so cheap, and I think everyone can do it. I say again and again, I tell to my 450 friends who have qualified as our alumnus from ICET, that in case you can do a cesarean section, in case you can do an MTP, you can do these testings. You're overqualified for this. You spend some time and you can learn this, or we can train our technicians to do it for you. So in case sperm is good, sperm will look white. In case it is dead, it will stain pink. The staining methods. And there are things called HOS testing, which we do prior to ICSI. It's a hyposmotic swelling test. Here we'll have curling of the tails. Very simple test. I think everyone of you can do it. It doesn't take much of time. Another thing is that patient says, doctor, I've heard I can undergo something called DNA fragmentation test. Should I do it? So what should be your answer? Is it the right test or not the right test? You should know that DNA is the most important part of the sperm, and DNA damage is pretty common nowadays. And this is one cartoon I've taken from the internet. But the message I want to give to you is that DNA damage will occur due to reactive oxygen species. And whenever DNA damage occurs, when we have something like this, we have DNA here and we have acrosome here. This is the DNA. When the DNA damage is occurred in the sperm, this DNA will go into a clump form. It will be clumped. So DNA is ineffective. So when we carry out DNA fragmentation index, it will look like a blue or a reddish DNA material. But in case the DNA is good, we'll defragment it ourselves and it'll all open up like a hello. This is the way a good DNA will look like. That's called DNA fragmentation index. And I think this test we are doing it routinely. Every day, 4 to 5 cases we do nowadays. And this is how it look like. A bad sperm will look like this, and a good sperm will have a halo around it. I just want to show this picture so that you're not scared of DNA fragmentation index. You must do it not as a primary test, but you must do it for any patient who's got varicocele, who's got unexplained infertility, anyone who's got recurrent pregnancy loss, anyone who's got recurrent IUI failure, or anyone who's got borderline or abnormal sperm analysis. They are the people I think we should be looking at them and doing it. Moving ahead, we get a common thing that my sperms have got pus cells. So every report which comes to us, they write that there are 4 to 6 pus cells present. What to do about this thing? You're confused. Always ask your doctor, your pathologist, or your andrologist that have you done staining? How do you know that they are pus cells? Because pus cells, any pus cell will look like a round cell. Around 5 round cells are permitted, but less than 1 pus cell is permitted. This you have to know. That's a basic definition we have. And you must learn how to diagnose a pus cell. That's very, very important. So to diagnose a pus cell, we've got multiple staining methods. We've got methods where we can put some peroxidase dye, put 1 drop of dye and it'll stain blue. So any pus cell which you are looking at, in case it has got peroxidase enzyme in it, that'll take up the color. That's called peroxidase staining method. And it's a very simple test. Anybody can do it. But my favorite always is that in case we can go in for a proper staining of the cell, we are able to identify the pus cell better. This is one test you must insist upon your andrologist or a pathologist to do it for you. Then another thing comes up. Should I examine the male? I'm a female gynecologist. I'm not comfortable. I think that in case as a female gynecologist or as a female andrologist, you can't examine the male, then I think we should not be doing this specialty, number 1, or we hire somebody to do it for you. But no man should go without examination. Present scenario is that males are not examined at all. Majority are not examining the male. In case you keep your hand on your heart, and at the end of the class, type in the chat box that I do or I don't do, I'll be very happy. Leave aside examining. We don't even look at the male. We don't even look at the male. Probably they're totally ignored. And in case we are very lucky, we take few drops of semen sample and we do analysis, which we don't know how to do also. We don't do morphology, we don't do pus cell reporting, but we do some unscientific reporting. And finally, we don't succeed. And then the whole story is going to repeat, and patients, they keep traveling from one doctor to another doctor. And finally, they'll go to some Hashmi Dawakhana and take some medicine from them. So we must do a proper history taking. We do complete examination. You must examine the male in totality. And what happens is that we have got couples who are not having a child, and they say they're happy, everything is fine, but they've got phimosis, and no one has ever checked them for phimosis. And every month I get 1 or 2 cases who come with phimosis, married, and they feel that's the way it is. No one has been checked them, no one has guided them. Large number of people have not consummated their marriage due to these problems. They are scared. So until we won't talk to them, I think it won't happen. So why don't we do it? We normally tell them to go in for sperm donation. They go for sperm donation and they're happy. This is one thing which we have to eradicate from our armamentarium from today onwards. Sperm donation, the last resort we should do. There are indications, we must do it. But otherwise, in case the person is able to afford the treatment, I think we should be taking help of our esteemed andrologists and urologists, or referring them amongst the people who can really do a good job for you and examine them. Another common problem, my patient has got dry ejaculation. Today I put across all the queries which You all people keep calling me and asking me. My patient, man, has got a dry ejaculation, nothing comes out. So always, it's a common thing. Don't ignore dry ejaculation. And what happens here is very simple, that the man is getting erection, he's getting orgasm, he's ejaculating, but there is nothing coming out. Nothing comes out barring few drops of bulbourethral gland secretions. But he's sure that he's ejaculated. He has come. What do? Always think about retrograde ejaculation. See his urine and you'll find some sperms there. And this is what we don't know, and we keep ordering for donor sperm. That he's got azoospermia. Don't do it. The sperms, as they're coming down, they don't come down through the urethra. They go up because there is something wrong with the bladder neck. I won't go into that details. It's a huge 2-hour subject. But here you should know that RJE is maybe dry ejaculation, and when the person has got an orgasm, he's got an erection and is ejaculated, no sperms come, think about retrograde ejaculation. Give him the bottle, take his urine, and you'll find sperms there. And it's very easy to get those sperms from there. How to handle an azoospermic man? Reports come, he's got no sperms. Immediately try to understand the sperms are not there, whether it is obstructive or non-obstructive. We had a long curtain raiser of 1.5 hours 2 weeks back on azoospermia, so I won't touch on that. But you should know that to diagnose azoospermia, we have to always carry out centrifugation. Simple terms. Do his FSH, testosterone, LH, depending upon whether it is obstructive or non-obstructive, and then you take it on. So what you should know is that you should diagnose azoospermia and also diagnose whether it is obstructive or non-obstructive. And for that, you have to examine the male. When his testes are normal size, his cords are palpable, normally he's got an obstructive azoospermia. And in such cases, we can get the sperms by putting the needle in his epididymis or testes. But nowadays we say you must carry out examination of FSH before doing anything. So this will give you confidence that he's got a normal testes. Because many times the testes may be normal, but he still may be having non-obstructive azoospermia. So just remember that in case there's a blockage somewhere, there's a methodology where we can take help of our trained urologists and andrologists. They can carry out vasovasotomy or vasoepididymiostomy. These can be done and they can help the man. So microsurgeries can be done cheaply and they're very effective. Other methods are what all? They are PISA, TISA, MESI. These are the methods which we are following every day. For my gynecology friends, they are very simple. They are like our bread and butter nowadays in our kitchen. There is a laboratory. We do it nearly every day. They are no longer those exotic techniques. They are common techniques and you must utilize the advantage. And I just saw the number. We have got 301 participants who have enrolled till now. Thank you so much for joining us in such large numbers. There are multiple methods by which we can do things. PISA, TISA, MISA, they all have their indications, contraindications, and we look at the DNA fragmentation indices at various places. We got microfluidics. There are multiple ways to do it. Simply, we just put a needle inside the testes or epididymis and take out sperms like this. As you can see here, sperms are taken out and we can use these sperms for ICSI. Here is a new technique called single sperm vitrification. Or a rare sperm vitrification. Never do a biopsy in your laboratory or in your OT in case you don't have qualification to carry out single sperm vitrification. Very simple technique, and nowadays we are all doing this. So take help of the people who can do it and only do the biopsy of the man when you have this facility. Otherwise, in case you get the less number of sperms, you won't know what to do with them. You won't be able to freeze them. So for few rare sperms, single sperm vitrification is a thing which we do. You can do an open biopsy and just this is onco testes. Yesterday, I was doing a panel discussion for the Ahmedabad group, cancer group. Onco testes is something like when we carry out micro tissue. We open the whole testes again. This is a case of leukemia. Open the whole testes, use a microscope, and then we take out the tubules, cut open the seminiferous tubules, and then you'll find one odd sperms sticking around. These sperms are tweaked. We tease them out with an ICSI needle and we take them out. And then these are the sperms which undergo single sperm vitrification and finally ICSI. These are the common techniques, things available to all of us. And my favorite friend is an ICSI machine where with this injecting pipette, we can take these sperms inside and then we can do ICSI directly or we can do single sperm vitrification. It's an ICSI, we all know about the ICSI, but many times in cancer preservation, when we get cancer patients with us, there's again one subgroup of people will come to us, cancer. Leukemia. You'll find that all these cells are blackened. Tubules are blackened out. This happens due to the metastasis in leukemia, a common condition. So coming to part 2, summary. What we have learned till now is that when you come to the summary part, important thing is that we should learn how to examine a male. We should learn the importance of examining a male. We should challenge our andrologists. We should challenge our pathologists because finally, for you, it is not a clinical correlation. For you, it is the patient. You can't write, please correlate clinically and send the patient off. You are the woman, you are the man or a boy and a girl across who's going to give them a child. So you have to learn how to do proper interpretation and you are banking upon the people who are interpreting it. So morphology, pus cell, vitality, motility has to be properly done as I've told you. Time to think and introspect. When we have a low sperm count, this means that there is no cause known. We don't know why the sperm count is low. Here we have a condition called idiopathic. So this is the most challenging thing for me. I don't know the reason of the low sperm count. Other condition is that we have some infections, some pus cells present. I'm happy here. I'm actually happy here. I'm happy because here I can actually treat them well and here I actually don't know, I'm confused what to do. So this is a thing which I will look for where we can actually treat him well. So one is idiopathic, another is when the cause is known. So when the cause is not known, it's antioxidants, and when the cause is known, it is antibiotics and antioxidants. So we have to, how do I handle a case of 𝙀𝙤𝙪𝙧? How do you all handle it? These are the common queries which I'm getting day in, day out. The role of clomiphene citrate. I find every prescription, everyone writes clomiphene. Like we give clomiphene to the females, we are giving clomiphene to every man for low sperm count. Don't do it. No clomiphene for the men until his FSH is low and testosterone is low. Simple. I won't go to much of details. Lack of time, clomiphene don't use. It's not recommended until FSH values are low and testosterone is low. I've seen the best of people giving people tablets and shots of testosterone. This poor guy's got a low sperm count. In case you give him testosterone, he'll have erectile dysfunction. He will have whatever sperms are present, they will also disappear. Testosterone is not indicated to treat male infertility. Remember, this is a contraindication. I'm writing in bold, it is a contraindication. There are few messages which you keep asking us, sending on our groups, so we keep taking them. Role of HMG and HCG in male testicular failure. Here you have to remember the male infertility, that whenever you have to give them HMG and HCG, don't start with HMG straight away. Always give HCG first. Give HCG first for around 2 months. This contains LH, and then you add HMG. This is the tip I'm giving to you. So initial for 6 to 8 weeks is only HCG, and then you add HMG. How do I handle a case of idiopathic oligoasthenotracheozoospermia? We come to this. It's again a challenging condition. Here, there is no cause found of the problem. We don't know why it happened. We don't know the reason, and we are actually tried everything. We have done all the testings, we have done all the clinical examinations, but still patient is having oligoteratozoospermia or asthenospermia, so we label them to be having OAT, IOT. We call it idiopathic OAT. What we discussed before was OAT, and this is IOT, and around 80% of them are due to reactive oxygen species. Just remember that ROS is very important for us to work. In case I'm talking to you, I'm getting oxidative stress in my body and I'm able to talk to you. In case there is no, for communication, for heart to beat, liver to work, kidneys to work, a man to get his erection, for ovulation to occur, sperm to fertilize, ROS is required. But there's a balance between ROS. When the ROS goes very high, immediately body's antioxidants, they come and they grab it. So when there's an imbalance between ROS, when the stress is more and ROS becomes more and antioxidants are less, then this will keep going up and then there's a problem we land up into, and they all lead to poor sperm count. So oral supplementation is the key thing for this thing, and it's proven beyond doubt that ROS, they exist and they cause problem. Multiple studies are there, but I just want to give you a small message that a large number of people, 80% have got oxidative stress as per the study by NIH. So another study says 40%. Time is going to come where every man who will be coming to our OPD will be undergoing ROS testing. Every man. The big study we done by Cleveland, USA. I was also part of that study. We found that ROS is a common cause of male infertility. And like we do hemoglobin TLC, DLC for any woman coming to us, or a man, we do semen analysis, we have to check his ROS also. But presently we're not ready for it. ROS is important for all these things. In case there is no ROS, this thing won't happen. For everything, ROS is important, but when the balance tilts, then there's a problem. So don't look at ROS as something very alien, which is bad, but always understand that ROS is good, but anti-oxidation mechanism has to be good in the body. And when it is bad, then the sperm count goes bad and it can affect the sperm plasma membrane. It can lead to the DNA damage. It can lead to the sperm counts. So now when we have IOT, we start treating the plasma membrane damage by giving them antioxidants. And this is what happens here. So we start giving antioxidants and the sperm motility is going to come back. But just remember that for anything to work, it will take around 2 to 3 months minimum. Don't be in a hurry by giving them AOX. It won't happen overnight. It may take 2 to 3 months. That's the way ROS works, from cancer to stress, smoking, alcohol, anything which we do, these problems can occur and we have to learn how to handle ROS being generated. Normally, we are banking upon antioxidants in the diet, but they don't work. They don't work anymore because we are not taking them as such. We're normally frying them. So before I go ahead, can someone tell me here, how do you feel we should take tomatoes? Tomatoes are very rich in lycopenes. So how do you advise tomatoes to a male? And anybody would like to comment upon this?
Salad, sir.
Salad, never. Never give tomatoes in a salad. If you give them in a salad, they won't work. Tomatoes have to be
never raw, always
sorted. Not sorted, gentle sorting. Just keep them over the tawa, just sort them. And that's going to activate lycopenes and carotenoids. In case you boil them, microwave them, or fry them, or take them kacha, it won't work. There are multiple things we have to learn, but time today is short. But this is what is happening to the man. In place of having this, he's having this. So there's a role of antioxidants, and they're making our sperms weaker. Sperms are becoming thicker. They are gaining more weight. Their DNA is getting fragmented. And finally, we need to add antioxidants, and this is what happens. It goes ahead and fertilizes the egg. And so there's a place of antioxidants and which we must give. So we have to know that this balance has to be maintained. And how to give antioxidants is also an art which we have to learn. So we have vitamin E, we have arginine, CoQ, zinc, melatonin, a lot of companies, a lot of people are selling products. We have to know what we have to take, but we have to know that these concept of AOPP is important. When AOPP is more, there is more damage, and to treat AOPP, we can give somebody melatonin. Melatonin works pretty well in all these cases. Multiple studies, I give you an insight into it, that these things matter. There are Cochrane studies which show that they work. So feel free to give carnitines. They'll increase the birth rate, carnitines or CoQs or melatonin. They can increase the live birth rate. They can decrease the DNA fragmentation. They're all forest plots from the Cochrane reviews. Just going through them, you should know what to give. This is a study which it was done along with Cleveland and some one Chinese unit, and we were all part of this group. And finally, we have found that we have to look for the oxidative stress in the semen sample the day they come to us, but probably we'll have to wait for a few more years for us to become more mature.